Okay, Chapter 32, Part 2, on psychiatric disorders and substance abuse. I think most of this will deal specifically with substance abuse. And by definition, substance abuse refers to the use, the abuse, and the addiction of um, any sort of substance. Most often we're talking about mind-altering drugs, whether they be stimulants, depressants, uh, hallucinogens. So we'll be talking about quite a few of those. Um, in some people with addictive personalities, uh, they'll have an all-consuming compulsion to acquire their substance. And by all-consuming, it means that they, certainly will go to great means um, to acquire it, even if it means stealing from family, friends, loved ones, that sort of stuff. Also, with substance abuse, they demonstrate a continued need, a consistent craving, um, and they know that they're abusing the substance, and they have a desire to curb their use. What occurs in some people is, let's say that they take a antidepressant and they drink, and somebody says, "Well, you're drinking too much," so they increase the amount of their antidepressant and decrease the amount of their drinking. Um, Typically, with substance abuse, doesn't matter what the substance is, it does affect your nutrition, your hunger, those other things, and as a result, malnutrition is another common symptom in substance abuse. And as I had mentioned, they will often combine the drugs in order to increase the effect as they develop a tolerance. Tolerance and withdrawal, over time, with repeated use, receptors become less sensitive, and so you need higher doses to do that. If you know somebody who can, put away a 12 pack, that certainly is a person who consumes quite a bit of alcohol, because for the average person, consuming a 12 pack of beer certainly um, would certainly give them a high enough blood alcohol that they couldn't even function. Um, the other issue with substance abuse is that if you suddenly stop the substance that you're abused to, it's going to lead to delirium tremens. It could lead to seizures, all those sort of things. So when we think about patients, let's say, for example, somebody whose drug of choice is a benzodiazepine, and if they overdose on their benzodiazepine, we all know that the antidote for that is romazicon. But if I give them the romazicon and reverse the effects of their benzodiazepine, they may, if they're a chronic user, experience seizures. And then the treatment for those seizures would be romazicon, which wouldn't work because, or would be a benzodiazepine. And the benzodiazepine wouldn't work because we just gave romazicon. So let's start with probably the most abused substance in the world, ethanol. Uh, it's the intoxicating ingredient found in liquor, wine, and beer. It is, again, the most commonly used and abused. People who have that unsatiable need to get their alcohol and who drink to intoxication every time they drink, even to the point where they black out. They can't remember what they did the night before. You're drinking before 10 a.m., all those sort of things certainly could be considered an alcoholic. Now, alcoholism is a true condition that has something to do with genetics, or it could be strictly a behavioral issue. And 60s, 70s, there was a lot of substance abuse going on, and children would grow up in environments where substance abuse was part of their daily life, and then when they became adults, well, they just repeated that cycle. So it wasn't that they were alcoholics or drug addicts, it was just that's the life they knew. This is probably a low estimate. 38% of all traffic fatalities are related to alcohol. It is a leading cause of death and disability in the United States, far more than heart attack or stroke. Certainly, excessive ethanol consumption increases your risk of both heart attack and stroke. As far as the routes and pathophysiology of ethanol, it is absorbed into the bloodstream through the digestive tract, 20% by the stomach, the remainder through the small intestine, and we can measure what is called a blood alcohol content, or a BAC, and it's measured in milligrams of ethyl alcohol per deciliter of blood divided by 100. And when measuring that, as you're certainly aware, the blood alcohol content of 0.08 would be an 8% blood alcohol, and somebody with an 8% blood alcohol or more is considered impaired and could be arrested for driving while under the influence. The alcohol is excreted through the urine, it's excreted through the lungs, and it's metabolized by the liver. If you're not a drinker, or you haven't had a drink and you're around people that have, you certainly can smell the alcohol on their breath as it's being excreted through the lungs. One other thing to know about alcohol is the metabolism in the liver turns the alcohol into formaldehyde. And formaldehyde, as you know, is what's used to keep people in a fresh state following their death, or a preservative, or preserve them. Ethyl alcohol is also the #1 cause of liver failure. You find it in bottles, cans, kegs. Of course, it's mixed with non-alcoholic beverages when we talk about, your rums and your vodkas and all those things, whiskeys, bourbons, scotches. All of those are now flavored to be more attractive to the population, and when mixed with orange juice or pop or any of those sort of things, then it does make the alcohol more palatable for those who don't drink frequently. But somebody who drinks frequently will often just drink it right on the rocks. The subjective effects and physical findings of somebody who's on ethanol just vary widely depending on tolerance. Initially, when you consume alcohol, it has a euphoric state. It does make you feel good, but alcohol by nature is a depressant. And the more that you consume, the more depressed you actually become. It causes you to lose your ability to make good decisions. It allows you to participate in risky behavior without thinking about the consequence. And certainly it destroys brain cells. And somebody who is a chronic alcoholic, in addition to taxing their liver and their pancreas, also taxes their brain. When consuming alcohol, the body must increase its metabolic rate in order to metabolize it. So tachycardia is common after you initially consume some. Vasodilation is common, and in high enough amounts, and again, that's going to vary from one person to the other, they may develop dysrhythmias. Long-term effects, of course, are liver toxicity. In patients who consume lots of alcohol over long periods of time, it's really hard on the liver. When the liver begins to fail, blood backs up into the system, and you get what's called portal hypertension. And when you get portal hypertension, you get esophageal varices, and of course those are prone to rupture in alcoholics or people who drink lots of alcohol when they vomit. Alcoholism, again, there's a biological reason for it, there's a psychological reason for it, and certainly a social reason for it as well. The other thing to keep in mind about ethanol is, even in somebody who doesn't drink a lot, following a binge, and there's a wide variety of different definitions of what binge drinking is, but following a binge, a day or two after the binge, the person could develop an acute pancreatitis. In fact, that's usually the number one cause of pancreatitis is alcohol consumption. We've all been told about certainly that chronic, long-term alcoholic who's emaciated and devoid of vitamin B and C and those other things. They will develop Wernicke's-Korsakoff syndrome, and it is the result of the inability to absorb vitamin B over certainly long periods of time. They can get confusion, odd movements, eye muscle paralysis, abnormal gait, hypothermia, hypotension, amnesia, and permanent psychosis, especially in those patients who are don't have vitamin B, don't have the thiamine, and we give them D50 for their altered mental status. We could precipitate this syndrome, causing a permanent psychosis. And as a result, we've all been taught that thiamine is something we would consider giving alcoholics, those especially that are malnourished, emaciated, and that may prevent that prior to giving them D50. Some differential diagnosis of ethanol intoxication include hyperosmolar hyperglycemic non-ketonic coma, and that's in those patients who their insulin works well enough to get sugar into the cells, but not well enough to keep their blood sugar low. And over longer periods of time, a couple weeks, months, their sugar rises. These are the folks that come into the emergency room severely dehydrated from the nursing home and have blood glucoses of 1200. So blood sugars can get really, really high in these sort of patients, which increases the risk of dehydration. Pancreatitis, diabetic ketoacidosis, hypoglycemia, meningitis, encephalitis, status epilepticus, because they may have seizures as a result of chronic ethanol drinking. Subarachnoid hemorrhage. As we age, our brains do shrink somewhat. Alcohol is hard on the vessels. People who drink a lot fall down a lot, certainly bumping their head, leading to some sort of hemorrhage. Ethylene glycol is antifreeze, and ethylene glycol back in the day contained a good amount of alcohol, and that's what kept it from freezing. So alcoholics would strain the antifreeze through bread so that they could get the alcohol, but they typically would end up with antifreeze poisoning, which could be lethal. Today's antifreeze does not contain alcohol. Lithium toxicity. This could also resemble somebody who's had an overdose of lithium. Therapeutic interventions when treating somebody who has alcohol intoxication to the point where they're unresponsive, they're at risk of vomiting, so protect their airway, assess their mental status. If they're in delirium tremens, then certainly IVO2 monitor, fluid bolus. As far as patient and family education goes, if a person drinks to the point where They wet themselves. Their speech is garbled. They are falling down. That is alcohol poisoning, and that's no different than any other poisoning. The person should be evaluated at a hospital because with that altered mental status, that puts them at great risk for potential aspiration, hypotension, and death. Now, cocaine is a CNS stimulant, so it's a central nervous system stimulant. It's a Schedule II medication, and it's one of the more frequent causes of drug-related visits to the ER, and that's illegal drug use because of the CNS stimulation. When you stimulate the central nervous system, it's like the part that you're stimulating is the sympathetic nervous system. So when you stimulate the brain and the spinal cord, it's like stimulating the sympathetic nervous system. It's like a big release of adrenaline, big release of norepinephrine and dopamine, and we'll see classic symptoms with this. This can be smoked, injected, can be taken orally, can be snorted. It blocks the dopamine reuptake, and as a result, there's a heavy activation of the brain's regard system. Cocaine is highly addictive. People who take cocaine, much like methamphetamine, which is a very similar drug, people who take these CNS stimulants, the very first time they take them could be lethal, depending on the dose. They often will get an intense high that they'll never achieve again because they burn the dopamine receptors in their brain when they take it the first time, so they won't ever get there again, and they end up chasing that. Those who obviously are concerned about the CNS excitement will do speedballing, and that's where they'll alternate doses of cocaine to bring them up and heroin to bring them down. As far as paraphernalia, you'll see things like mirrors and razor blades, small hollow tubes or straws or a pipe, so that they can get the cocaine into their body. The reason certainly that people take any mind-altering drug is for the euphoria, intense energy, but certainly cocaine can lead to seizures, tactile hallucinations occur, bizarre, erratic, violent behaviors are possible. We saw that in excited delirium, in the body packers in the 90s in Miami. They'd come in from Cuba or come in from the South, and they would have condoms full of cocaine either stuck up their rectum or they would swallow them and defecate them out later. And if those condoms broke, then they had this huge amount of cocaine inside of them, and they would suffer from excited delirium, and some would even die. You'll get dilated pupils because of the CNS excitement, but they're going to be slow to dilate. They'll be tachycardic. They'll have vasoconstriction. Within the first hour of cocaine use, there's a 24 times greater risk of a heart attack, particularly if you have a weak heart. Sudden death can occur as well. It affects the temperature regulation centers in the hypothalamus, so you can fry your hypothalamus and not be able to regulate your body temperature, and actually get temperatures high enough to cause brain damage. Long-term effects, of course, like any drug, is going to be dependence and addiction, heart disease, narrows the cerebral arteries, decreases blood flow to the brain, impairs cognition, loss of sense of smell, especially if you're snorting it, weight loss and malnutrition. As far as tolerance and withdrawal goes with cocaine, there's lethargy, severe depression, anxiety, anhedonia, and intense cravings for the drug itself. Differential diagnosis may be alcohol intoxication, encephalitis, hypoglycemia, hyponatremia. Panic attack seems like more of a common diagnosis in the recreational user who takes it and can't handle the increase in CNS excitement and presents like a panic attack. Certainly with a rise in blood pressure and vasoconstriction, all those other things, it can lead to strokes, both ischemic and hemorrhagic. It may resemble an anticholinergic toxicity. When you think of your cholinergic system, your parasympathetic system, when that system is stimulated, your heart rate slows down, you sludge when you have a cholinergic toxidrome, and so taking a CNS stimulant where everything is up, that will mimic a anticholinergic toxicity. An antidepressant toxicity, particularly your tricyclics and your SSRIs, certainly can lead to, if you overdose on your antidepressants or quickly withdraw from your antidepressants, it will cause CNS excitement. Benzodiazepine intoxication, methamphetamine, hallucinogen, mushroom intoxication, PCP intoxication. So many of these other mind-altering drugs also stimulate the central nervous system. Therapeutic intervention: if everything's up, you got to bring it down. IVO2 monitor. Understand that these patients could become very violent. Call police as needed. 100% oxygen by non-rebreather mask, 12-lead ECG, because they could have a STEMI equivalent in patients who take cocaine. It may cause, with the vasoconstriction, coronary artery vasospasm, and they can actually have chest pain, and when you hook them up to a 12-lead, can actually show coronary artery spasm, which will look just like STEMI. However, when they get into a cath lab, there's no occlusion to the vessels. Fluid bolus: certainly if they've been sweating a lot, they don't need large amounts of fluid, but perhaps a 250 ml bolus. Again, they're going to have chest pain, and typically when we think of non-cardiac, or we think of STEMI equivalent chest pain in somebody who's taken a hit of cocaine, we think of Mona, morphine, oxygen, nitroglycerin, aspirin, and while those things may be necessary, it's most important to bring them down. So lots and lots of benzodiazepines is the treatment of choice for heart-related chest discomfort from cocaine use. Ecstasy, it's also known as MDMA. It's also known as Molly. It is a methamphetamine with a mescaline structure. It comes in a pill form. It's a Schedule I drug, and we've seen a huge increase in the use of ecstasy over the last decade or so, particularly in adolescents and young adults. Miley Ray Cyrus has one of her songs that references the use of Molly, so it has been popularized by people like that. Routes and pathophysiology: it only takes about 1 to 2 milligrams per kilo to be effective. Again, it's mostly in tablet form. The effects begin within 20 to 40 minutes. They last about 6 to 10 hours. And ecstasy blocks the reuptake molecules on the presynaptic neuron. It floods the synapses of brain with serotonin. And as a result, with that serotonin, you get quite a euphoric state. Candy flipping is something that occurs with the use of ecstasy, and that's where they'll combine LSD or acid with the ecstasy for a more intense visual and mental psychedelic experience. That also, again, increases the overall body experience, or the overall feeling of euphoria. Stuffed animals might be present in raves. You see a lot of glow sticks because of the visual intensity. Methanol rub or a Vicks inhaler. the intensity is so much more increased when they would smear a little Vicks vapor rub under each nair, or with the Vicks inhaler they would reverse it and actually blow the mentholatum into somebody's mouth, which would again give them just a huge intense blast of the mentholatum. People on ecstasy have a tendency to teeth grind. And again, everything on ecstasy is intensified. So they'll often have lollipops or suckers or a ring pop. The favorites are blow pops and pixie sticks. The blow pops certainly would prevent them from teeth grinding. And then the sweet and sourness of a pixie stick is again greatly intensified on ecstasy. They're going to have increased energy, euphoria, heightened sexuality, expanded consciousness, but they're also going to have tachycardia, hypertension, hyperthermia, dilated pupils, clenched jaw, teeth grinding. With doses around 4 to 5 milligrams per kilo, you get a sharp body temperature spike, rapid severe dehydration, which can lead to brain damage and death. Withdrawing from ecstasy, particularly if you've developed a tolerance, could create depression, anxiety, and fear. Could also have a rebound sympathomimetic toxicity. Sympathomimetics are drugs that mimic what happens when you stimulate the sympathetic nervous system. Long-term effects, decreased memory and cognitive impairment. Differential diagnosis, sort of any of the exact same things that we saw with cocaine, because it's a very similar drug. Therapeutic interventions, just like with cocaine, IVO2 monitor, you're going to have to cool them down if they're hot, fluid administration for dehydration, let certainly family and the patient know that ecstasy is not safe. Certainly the hyperthermia could cause severe brain damage, and the dehydration could cause cardiac arrest. Methamphetamine is a white powder form. It can be in crystal form, which is far more pure. When they grind the crystal up and then step on it with baby laxative and other white powders, that's the problem with methamphetamine, is that you never know the actual percentage of meth that's in the powder. You could be getting a quarter percent meth powder and take it and a certain amount and have the effect that you want to achieve, and then unknowingly get 100% meth powder, take the same dose, and now we've got a problem. The epidemiology and demographics, methamphetamine is very popular in the 18 to 25-year-olds, particularly males, seen more with Native Hawaiians, Pacific Islander, and American Indians. It's in crystal form, can be smoked. In powdered form, it can be smoked, ingested, injected, snorted. Onset about 30 seconds, lasts for 24 hours. As far as paraphernalia, you're going to see pipes if they're smoking it, syringes if they're shooting it up, short straws if they're snorting it. And it is made in meth labs across the United States. However, the vast majority of our methamphetamine comes from California and Mexico, where they use what's called a red phosphorus method to cook it. It's a very early method, very dangerous method. Around here, meth labs, there still are some that are using anhydrous ammonia. Many have graduated to the shake and bake method to create their methamphetamine. It's going to have, a CNS stimulant effect, just like cocaine does. Binging, craving the drug, the CNS excitement, you'll see tachycardia, hypertension, tachypnea, hyperthermia, palpitations, PVCs. You'll be dehydrated, abdominal cramps, twitching, They may be pale, dilated pupils, tweaking and twitching, very similar, scratching and rubbing the arms, tics, that sort of thing. Hallucinogens and delusions are common on methamphetamine as well. Whenever withdrawing from a CNS stimulant, you get just the opposite effect, where depression, anxiety, fatigue, paranoia, aggression, and just like with cocaine, when you do your first hit of methamphetamine, it burns out the dopamine receptors in the brain, and you'll never achieve that same intensity that you had the first time, so you end up chasing that. Long-term effects, severe permanent brain damage, you burn the brain neurons out, loss of cognitive function, and because of the increase in metabolism, the poor nutrition, a person on methamphetamine seems like, or certainly appears, that they age really, really fast. Differential diagnosis, again, we're right back to all those differentials that you would see in anybody taking a CNS stimulant. Therapeutic effects, again, they could suffer from excited delirium, so they could be violent. Watch your own body language, watch the patient's body language for potential for violence. If the scene is unsafe, have police present. If it's an uncomplicated intoxication, it's just supportive care. Otherwise, 100% oxygen, 12-lead ECG, IV access, give some fluids. With the chest pain, you're not going to treat it like heart with Mona, but more benzodiazepines. And then if that doesn't bring them down and that doesn't make their chest discomfort go away, then certainly follow your STEMI protocols. Excited delirium is paranoia, aggression, hyperthermia, increased strength, pain intensity, and sudden death. It typically occurs in people who are restrained. I do believe that Eric Garner certainly fit the classic presentation of somebody who dies during a restraint, heavy-set male, warmer temperature, on some sort of stimulant, struggles with police, may end up in a position where they're lying flat on the ground on their belly. Now, in some of the pictures, he was certainly on his belly for a bit, and that's something you just can't help when you're trying to restrain somebody. But it's important that you prevent positional asphyxia by getting off them as soon as you can, get them over onto their side so that they can breathe. Long-term stimulant abuse will lead to heart disease. A genetic fault may prevent the brain from adjusting to drug receptors in the limbic system. Men aged 20 to 40 years, a long history of stimulant abuse. They'll be tachycardic, hypertensive, hyperthermic, very combative. They'll need to be restrained, calmed and quieted. As a result of the struggle, again, they may go into respiratory arrest or cardiac arrest. Now, there's a wide variety of hypotheses of why that happens. Certainly just the stress on the heart is one of the hypotheses. Rhabdomyolysis, or damage to the muscles, is another hypothesis. When you damage a muscle, you not only release potassium, raising the potassium level, but you also flood large amounts of volume into the muscle sheath and into the damaged muscle itself. The muscle is going to release myoglobin, which plugs the kidney. The large amount of water that is pulled into the damaged muscle can actually lead to hypovolemia. So rhabdomyolysis certainly is a hypothesis. Cardiac stress is a hypothesis. Positional asphyxia is a hypothesis. And then metabolic acidosis from the struggle certainly is a hypothesis as well. The interesting thing about excited delirium is it is not a accepted diagnosis. However, the American College of Emergency Physicians have endorsed it as a diagnosis. And people in excited delirium who struggle in fight with their restrainers and go into cardiac arrest don't survive. Certainly differential diagnosis, restrained asphyxia, cocaine toxicity, methamphetamine, cardiovascular stress, rhabdomyolysis, all reasons for excited delirium. Therapeutic interventions is to prevent it from occurring in the first place. You might have to chemically restrain them. You might have to physically restrain them. And because of the, certainly type of situation that you're faced with, law enforcement is involved, tasers are involved, and if it leads to in-custody death, we certainly have seen the fallout of that. 100% oxygen, rapid cooling because they're going to be really, really hot, large doses of benzodiazepines to bring them off their stimulant, and some will start using excited delirium cocktails where they'll put that Geodon plus a benzo, or Geodon plus Haldol, or Haldol and a benzo, because often patients in excited delirium takes large amounts of benzodiazepines to calm them down. Now we're going to talk about some depressant medications, looking first at the sedative hypnotics. Sedative hypnotics cause powerful relaxation and euphoria. They relieve anxiety, they relieve insomnia, they help control seizures, that's your benzodiazepines, and they include barbiturates and benzodiazepines. Sedative hypnotics are ingested through prescription medications, or they can be injected. They cause you to be sleepy, have a sedated feeling, reduce your anxiety or worry. Often taken with alcohol will lead to bradycardia, slowed respiratory rate, and death. Sedative hypnotics are a very common drug that people will take when attempting to commit suicide by drug ingestion because they just go to sleep. Tolerance and withdrawal. Certainly withdrawal from sedative hypnotics could cause a surge of brain activity which would lead to seizures. Long-term effects include addiction, and then a tolerance, like with all drugs taken over time, which require you to then take more to get the same effect, can lead to amnesia, irritability, and anger. Some differential diagnosis, certainly alcohol intoxication, some sort of brain injury, delirium tremens, diabetic ketoacidosis, brain bleeds, hypertensive emergencies, hypoglycemia, metabolic acidosis, or brain tumors. As far as treating, secure an airway if they are unable to control it themselves, establish an IV, and let family and friends know these medications are addictive and that they do have serious side effects of slow respiratory rates, altered mental status, and an increased risk of aspiration. GHB, gamma hydroxybutyrate, is a white powder. It is given for narcolepsy. It essentially is liquid ecstasy. The use of GHB has been greatly reduced in the past years because it's no longer available at your GNC. Gamma hydroxybutyrate became really popular with bodybuilders, particularly those that were taking anabolic steroids. The GHB would dampen their roid rage that they got from taking their steroids. When you take GHB, particularly with alcohol, the effect is greatly intensified. 1 or 2 beers and some GHB, and you've got rapid unresponsiveness, nausea, vomiting, tremors, agitation, hallucinations, bradycardia. When they overdose on it, Cheyne-Stokes respiration, seizures, and death. When taken, certainly during the withdrawal of GHB, it's going to be like DTs: tachycardia, hypertension, tremor, confusion, nausea, vomiting. They may have hallucinations, paranoia, anxiety, and these withdrawal effects can last 3 to 15 days. Long-term effects are unknown. It has caused death, so it's now illegal to purchase, but a precursor to GHB is 1,4-butanediol. And in the body, when you take 1,4-butanediol, it is metabolized into GHB by the liver. So you get the same effects by taking this 1,4-butanediol. 1,4-butanediol is a chemical that's used to make spandex, rubber products, those sort of things. It is a tasteless, odorless, colorless liquid that certainly when poured into a drink could cause a rapid onset of unresponsiveness, and therefore also has been linked to date rapes. Routes and pathophysiology, because it's a depressant, these drugs are a depressant. It could be could mimic an opioid toxicity. Opioid toxicity has a classic triad presentation. If somebody's overdosed on their heroin, which is an opioid, you're going to see altered mental status, slow ventilations, and pinpoint pupils. So that's just a classic presentation. It could resemble ETOH intoxication, and certainly people taking 1,4-butanediol or taking GHB often do so while drinking, so you'll smell the alcohol and just assume that they're intoxicated. You might think it's a suicide attempt. Certainly could mimic a neurologic illness or an injury, and again, it can be used as a date rape drug. Therapeutic interventions are to protect the airway primarily. Atropine for the bradycardia, however, that's controversial, but certainly something you could consider. With the GHB, I saw it first in the 80s, again in bodybuilders. We had a bodybuilder who was having seizures outside a club. We got there, totally unresponsive, seizing, got him to the hospital, stopped his seizures, did a drug screen. It does not show up on a drug screen. So we had no idea. The guy's intubated, taken by ground to a larger facility, and as they're pulling into the facility, he immediately wakes up, pulls the tube out of his throat, and wonders what's going on. That's how quick the turnaround is. Opioids include analgesics. They include your morphine, your codeine, your oxycodone, heroin, opium. They come in pills, tablets, and syrups. And when we say morphine and codeine, that certainly includes all their derivatives. Oxycodone, hydrocodone, Percodan, Darvon, Darvocet, APAP with codeine. There's just a wide variety of these type of medications. They can be injected, intranasally, given. They can be smoked, like in the case of heroin. Has a 5 to 8 minute onset, and again, the reason for taking them is the euphoria that they provide. So you might see a torch or spoon or syringe, because some of these have to be heated up to make a liquid form, which then can be drawn up into a syringe and administered intravenously. The subjective effects and physical findings that you'll see in people with opioids: state of euphoria, and as they crash, depression. Pupils are constricted, decreased heart rate, orthostatic blood pressure changes, pulmonary edema, which certainly can lead to their death as well, along with the decrease in respiratory rate. Opioid withdrawal can occur within a few hours of stopping their medication of choice, or certainly withdrawing them quickly with something like Narcan. During the withdrawal, there may be lots of yawning, a runny nose, nausea, vomiting, diarrhea, sweating, muscle pain, bone pain, lots of anxiety, and tachycardia. Long-term effects of using opioids, certainly if they're given intravenously, is scarred or collapsed veins, blood and heart valve infections, again from sharing needles, skin abscesses, ischemic conditions out in the limbs, and certainly bloodborne pathogens like HIV and hepatitis. Differential diagnosis because of the slow heart rate, the not breathing, cardiac arrest, alcohol intoxication, GHB intoxication, or a dissociative intoxication. Therapeutic interventions protect the airway. They may need to be endotracheal intubated in severe cases. The lungs have to be adequately ventilated, and certainly Narcan can be given either IV, IM, or intranasally. And in 27 states, Narcan is allowed to be given by law enforcement, and in 17 states, Narcan is allowed to be carried by family and friends. Certainly, smoking or snorting heroin is just as dangerous as injecting it. So some people think, well, if I don't inject it, I'm not going to get HIV or hepatitis or have those issues with my veins collapsing, but it is still just as dangerous. Marijuana, also known as cannabis sativa, the tetrahydrocannabinol, or THC, is the primary component in marijuana that certainly causes the euphoria. Marijuana has also been very similar. It would be hashish. It's a Schedule I drug. It is the most widely used illegal drug in the United States, but it is, as we know, legal in several states: Washington, Colorado, District of Columbia. THC enters the bloodstream from smoking the marijuana. You certainly can eat the marijuana plant itself in, the good brownies, or the oil of the plant is being extracted and used as a medication to treat some type of seizures. As far as paraphernalia goes, certainly cigarettes, cigars, pipes, rolling your own sort of supplies, and grow lamps if they're growing their own plants in their home. The subjective effects and physical findings in somebody who's intoxicated on marijuana include an alteration in their sensation, their perception, an alteration in thinking. They're not coordinated, very relaxed, euphoric, sleepy, mild tachycardia and bronchodilation, get the munchies, certainly an increased appetite, dry mouth, urinary retention, and can, with the tachycardia, certainly cause angina in somebody with heart disease as well as a myocardial infarction. As far as tolerance and withdrawal go, just like any drug, people who take marijuana can develop a dependence and an addiction to it as well. Lack of marijuana in somebody who is addicted certainly causes irritability, insomnia, nausea, decreased appetite, and restlessness. Long-term effects, the amount of tars and harsh chemicals in a non-filtered joint can lead to throat and pulmonary tree damage. There's 3 times as much tar and 5 times as much carbon monoxide as in cigarettes. Could cause a spontaneous pneumothorax. They're seeing quite a bit of pneumomediastinum in patients who are smoking the marijuana, and so they've seen an increase of this in Colorado, and it's essentially caused when they inhale the marijuana and hold the smoke in their lungs and end up coughing against a closed glottis. That increases the intrathoracic pressure, ruptures the alveoli, and causes air to leak into the mediastinum. They're going to present with chest pain, more of a dull ache, that sort of presentation. It is not life-threatening, but certainly a nuisance. The hippocampus can be affected as well. Somebody who is on marijuana, certainly you could think also is an alcoholic or has ethanol intoxication or suffering from an anxiety disorder or bipolar disorder or depressive disorder. Maybe they've taken a hallucinogen or have done an inhalant, or maybe you think they've ingested opioids. Certainly in the stages where they're extremely excited, you may think just the opposite, that instead of something that's a depressant in the system, that they're experiencing the signs and symptoms of a panic attack or schizophrenia or cocaine abuse, as well as dissociative drug abuse. Dissociative drugs disassociate you from reality. Therapeutic interventions, a very calm and coaching approach, treat the dyspnea and the chest pain, and long-term use of marijuana certainly is harmful. Inhalants include glue, shoe polish, gasoline, hydrocarbons, whippet, nitrous oxide is in those canisters of whipped cream, and so inhaling the nitrous oxide is something that we see being done. Seen more in teenagers, young adults, and males. You can add into there the hydrocarbons are in those propellants like the head cleaning compressed gas cans. So inhalants are inhaled into the lungs. They're absorbed into the bloodstream through the alveoli. They pass freely into the blood-brain barrier, but certainly inhaling those fumes instead of oxygen can lead to hypoxia, hypercarbia. So you might see the compressed air containers laying around, plastic bags, whipped cream canisters, those sort of things. Inhalants will cause euphoria. Speech will be slurred. They'll have a staggered gait. They may be hallucinating, maybe drowsy or sleepy, maybe uninhibited, do impulsive things, and as a result suffer injury. Certainly if they have any sort of asthma, they can have a severe life-threatening status asthmaticus leading to suffocation. Depending on what it is they're huffing, they may have that strong chemical odor on their breath. They may even have the color of the paint around their mouth if they spray it into a bread sack and huff it that way. As far as tolerance and withdrawal, occurs when these problems may occur when they switch their chemical, when they go from one type of huffing agent to another. It causes frontal lobe damage. It lowers intelligence. It impairs decision making and leads to further abuse. Patients develop insomnia, irritability, jitteriness, nausea and vomiting, and tachycardia. Certainly long-term effects on inhalants might lead to suicidal ideations, abuse into other drugs. The huffing may damage the heart, the lungs, liver, the kidneys, the brain, may lead to congestive failure, renal failure, immune system inhibition, and the brain shrinks faster, could lead to dementia and loss of coordination. Differential diagnosis, unless you smell what it is they're huffing or see the paraphernalia, it certainly could resemble alcohol intoxication or stimulant or hallucinogen or a dissociative, but it could also look like a mild traumatic brain injury. Therapeutic intervention, keep the scene safe. Remember that some of these fumes are flammable. So remove them from those fumes. Airway control, 100% oxygen. Monitor their pulse oximetry, their end-tidal CO2 if possible, their ECG. Avoid epinephrine because they're already stimulated, and prevention and education is the cure. Hallucinogens include things like mushrooms, certain cactuses, mescaline, peyote, LSD, PCP can also be included in this list of hallucinogens. They distort and they distort your perceptions of reality. 10 to 20% occasional use in people who do use them. They don't use them that often. That's why we don't see a lot of it. And when they do, they're very discreet. They don't take enough where they end up in an emergency room. May include high school students, third most common used drug in that age group, particularly mushrooms. They can be ingested. They can be absorbed through the skin. They alter your concentrations of serotonin and norepinephrine. 30 to 90 minute onset. Many of these hallucinogens, particularly LSD, the dot candy on paper, when people came out with the candy on white paper and the little dots, people with LSD had figured out a way to do that with the LSD as well. So you may see what appears to be sheets of white paper with candy dots, when in fact those dots are LSD. People trip when they take this drug. They have visual hallucinations. They have a distortion of space. They are labile. They have intensified memories, and time moves slowly. If a person stops the medication, they can be completely through the body in a few days. Certainly the long-term effects are melancholy and mania, as well as flashbacks. Therapeutic interventions, calming and comforting, and trauma management. There just really isn't a lot of treatment for somebody who has taken a hallucinogen. Just if they're tripping and they're hallucinating, just making sure that they're safe and they don't get hurt. There's quite a bit of science that is now not certainly supporting the use of hallucinogens, but indicating that hallucinogens are essentially harmless. Differential diagnosis, dissociated intoxication, alcohol intoxication or withdrawal, ecstasy, excited delirium. Dissociatives distort sight, sound, and perception. They cause a detachment. So often considered hallucinogens. Probably the difference here is the distortion in sight and sound and a detachment from reality, and include PCP, ketamine, and dextromethorphan. Dextromethorphan, commonly found in cough syrup. Kids were buying the dextromethorphan type of cough syrup and then drinking it to get the dissociative effect. It can be injected, it can be ingested, it can be snorted or smoked. The effects occur within minutes, and you might find a plastic inhaler. It causes euphoria, but also can cause agitation, violence, and rage. Patients on dissociatives have really unpredictable behavior. In excess, they can be unresponsive, posturing, muscle rigidity, hyperthermia. When they talk about K-land, that certainly is reference to ketamine and the ingestion of ketamine. As a paramedic, certainly that ketamine can be used very similar to etomidate with fewer cardiovascular effects. Dissociatives, again, will cause the hallucinations and distortions of space, time, sight, and sound. Severe withdrawal for ketamine. When they take ketamine and they quickly try to withdraw from it, the DTs are far worse than other dissociatives. They may crave certainly these drugs, once they've had them, dysphoria, again, disassociation from what's real, sleep disturbances. Long-term effects will cause decreased memory, decreased attention, decrease in cognition, and flashbacks. Somebody on a dissociative, again, may be thought of as having a psychotic event or schizophrenic, as well as intoxicated or taking some sort of other mind-altering drug. Therapeutic intervention, certainly if they're violent, irrational, or combative, then you want to have law enforcement present. Many people on PCP would develop just superhuman strength. I saw one individual rip through 4-point leather restraints while on PCP. These dissociatives certainly may be similar to excited delirium, so you treat it the same way. There's no sense in trying to talk them down because they're not in the part of their brain where they can reason. So we're going to give them airway, supplemental oxygen. Meth labs, I'm going to talk briefly about meth labs. They're not as common as they used to be. Iowa used to be the meth capital of the Midwest, certainly if not of the country. A lot of methamphetamine was being produced in old farmhouses and places that were quite rural. Major thoroughfares running east and west, north and south, certainly allowed it for the the disbursement of the meds to Chicago and other places. Some of the common ingredients used to make methamphetamine, it really depends on the method. There are 4 different methods of making methamphetamine, and each one, as you go along, requires fewer steps and fewer ingredients, but all of them use just nasty ingredients in order to separate the methamphetamine from the Sudafed. If you certainly find yourself in a methamphetamine lab, you need to evacuate. There are dangerous things in there, not to mention highly flammable substances, strong acids and bases, as well as the potential for deadly gases like phosphine. They're saying if you find yourself in a meth lab, don't stop the chemical reactions, just turn off the heat source. And there's just not many people cooking meth with heat. It's just too dangerous. It led to explosions and fires. That's why they went to anhydrous ammonia, because with the anhydrous, they could put the anhydrous in their slurry, and anhydrous's affinity to water would absorb the water out of the slurry and make the crystal meth twice as fast as with heat. Drugs used for sexual purposes as well as club drugs include ecstasy. We talked about some of the things just because of the heightened intensity and euphoria, and a heightened visual stimulation, heightened taste, heightened sexual stimulation. Ecstasy is certainly a popular club drug. Ketamine, again, because of its disassociation, and same thing with dextromethorphan. To get cough syrup with dextromethorphan, typically you have to get it from the pharmacist now. Certainly these drugs can help facilitate sex in people that may have some problems performing sexually, but also can lead to sexual assaults. These drugs may cause impotence, impotence as well, and I don't know that any of them are used with the treatment for erectile dysfunction. So one thing that you'll see, particularly with ecstasy or methamphetamine as well, is because of the intense arousal that people with these are obsessed with pornography. Sexual assault occurs from CNS depressants, GHB, alcohol, and Rohypnol. You can add 1,4-butanediol to that. We don't use any chloral hydrate anymore. Certainly, chloral hydrate is a sedative, and Mickey Finn was running the Longhorn Saloon in the south side of Chicago, and his patrons would come in and he would slip them some chloral hydrate or slip them a Mickey, and they would go unconscious, and he'd take them out in the back and take all their money out of their wallet and just leave them laying in the alley, and then when they woke up and all their money was gone, they just thought they had a really good time. So that was one of the original sort of drugs like that, but now they're using CNS depressants with alcohol, GHB with alcohol, alcohol by itself, 1,4-butanediol with alcohol, and Rohypnol with alcohol. Some designer drugs include one of the newer ones on the market, or one of the newer ones certainly out there, is called Flakka, and it's an amphetamine-like drug that has the same effects as Molly and ecstasy. It's shown up in 6 states south of us, south and east of us, and are certainly to be here soon. We already are dealing with bath salts, K2 or spice. Certainly neither is a bath salt, neither is a potpourri or a spice, and when ingested cause excited delirium. All right, so with that, we'll end our lecture, and I will talk to you soon.